So, what is benign prostatic hyperplasia? Benign prostatic hyperplasia is enlargement of the prostate. Usually, it is presented with lower urinary tract symptoms. So, if an old male presents to you with lower urinary tract symptoms and his digital rectal examination reveals a large, firm, and smooth prostate gland, then you will suspect benign prostate hyperplasia. So remember these 2 points to make a diagnosis of BPH. That is, an old man complaining of lower urinary tract symptoms plus DRE reveals a large, firm, and smooth prostate. What are lower urinary tract symptoms? Lower urinary tract symptoms are divided into uh, categorized into three types of symptoms. One is voiding symptoms, second is storage symptoms, and third is post-micturition symptoms. So, voiding symptoms, which are due to obstruction, they include because there is obstruction to the flow of the urine. So, the urinary flow will be weak or intermittent. There will be straining, hesitancy, and terminal dribbling, and incomplete emptying due to obstruction. And the storage symptoms are mostly irritative due to irritation of the urinary bladder, that is urgency, frequency, incontinence, and nocturia. And there will be post-micturition dribbling as well. So an old male with these symptoms plus digital rectal examination reveal a large, firm, and smooth prostate. This point is important because prostate cancer will also present with lower urinary tract symptoms. But in prostate cancer, DRE will reveals a rough prostate, rough nodular or irregular prostate gland. So an old male with lower urinary tract symptoms and smooth prostate gland, your diagnosis will be BPH. And an old male with lower urinary tract symptoms and irregular or nodular prostate and raised PSA, your diagnosis will be prostate cancer. Treatment option for BPH include selective alpha-1 blockers such as tamsulosin. Alpha-1 blockers will cause relaxation of the smooth muscles that are present in the prostate gland. So the patient's symptoms, lower urinary tract symptoms will improve with the use of tamsulosin. And if the patient also has hypertension that need to be treated, then I will go for less selective alpha blockers such as prazosin and doxazosin or terazosin. 5-alpha reductase inhibitor such as finasteride, they can also be used in the treatment of benign prostate hyperplasia. They inhibit the conversion of testosterone to dihydrotestosterone, and dihydrotestosterone basically increases the size of prostate gland. So that's why 5-alpha 1 reductase inhibitor can also be used in the treatment of benign prostate hyperplasia. When we are going to use alpha 1 blockers and when we are going to use 5-alpha reductase inhibitor, there are specific indications. If the patient is only having lower urinary tract symptoms and his prostate is not that much enlarged, only lower urinary tract symptoms, then we will use alpha 1 blocker such as tamsulosin. And if the patient is having urinary tract symptoms plus significant prostatomegaly, so lower urinary tract symptoms plus enlarged prostate gland, if the prostate gland is more than 30 gram and or PSA level is more than 1.4 nanogram per milliliter, then we will use 5 alpha reductase inhibitors. So if there are only lower urinary tract symptoms, then alpha 1 blocker, and lower urinary tract symptoms plus prostatomegaly and raised PSA more than 1.4 nanogram per milliliter, then we will use finasteride or 5 alpha reductase inhibitors. And severe lower urinary tract symptoms and prostatomegaly, then we will use combination of alpha 1 blocker and 5 alpha reductase inhibitors. A little detail about 5 alpha antagonist. They decreases the smooth muscle tone of prostate and bladder. That's why they should be offered to men with moderate to severe voiding symptoms. Adverse effects of alpha 1 antagonists include because they inhibit the or they causes the smooth muscle relaxation that are present in the blood vessels, so they can cause postural hypotension, dizziness, dry mouth, and depression as well. What about 5 alpha reductase inhibitors? The example of 5 alpha reductase inhibitor include finasteride. Finasteride and block the conversion of testosterone to dihydrotestosterone. Dihydrotestosterone basically acts on the prostate gland and increases its size. Unlike alpha 1 antagonist, finasteride will reduce the prostate volume and size, and hence it may slow down the disease progression. This, however, takes time and symptoms may not improve for 6 months. And they also decrease PSA concentration by up to 50%. So that's why if there is prostatomegaly, if the prostate is larger than 30 gram or PSA greater than 1.4 nanogram per milliliter, then our drug of choice for the treatment of BPH will be finasteride. And if there are only lower urinary tract symptoms, then alpha 1 antagonists such as tamsulosin will be used. Important side effects for tamsulosin is postural hypotension, dizziness, and dry mouth. And because 5 alpha reductase inhibitor, it blocks the conversion of testosterone to dihydrotestosterone. So that's why it can cause erectile dysfunction and ejaculation problems and reduce libido, etc. And if the patient does not get better with this medical treatment, then we can go for surgery that is known as TURP, transurethral resection of the prostate. So this was all about the diagnosis and treatment of benign prostate hyperplasia. I hope it's clear to everyone. If there is any question, then you people can ask.
You said something about severe lower urinary tract symptoms. So what was that? I just missed out something. Like after the alpha 1 blockers, which is given in the low urine tract symptoms only,
So
and
if
for
the lower there are
if it is
uh,
severe, then what to use that?
if there
Severe.
is only lower urinary tract symptoms, then you will give alpha 1 blockers. And if there is prostatomegaly along with a lower urine, if there is prostatomegaly and raised PSA, then you
Yeah.
will use finasteride, 5 alpha reductase inhibitors. And if both the symptoms are present, lower urinary tract symptoms as well as prostatomegaly and raised PSA, then you will use the combination of both tamsulosin plus finasteride.
Okay, that's fine. Thank you.
I remember that BPH can cause acute urinary retention. So if an old male or if an old age patient present to you with acute urinary retention and he is a male, and then the first thing that you will think of is BPH or benign prostatic hyperplasia. And to relieve the urinary obstruction, we will insert a catheter. So a question was asked in the previous exams that the patient presented with acute urinary retention due to BPH, and a catheter was inserted which relieved his symptoms. What is the next step in the management of this patient? Remember that if patient symptoms improve after inserting a catheter, then the next step to do before surgery is that prescribe tamsulosin and refer for trial without catheter. So before jumping to surgery, in a patient who present to you with acute urinary retention due to BPH, you will prescribe tamsulosin and refer for a trial without catheter. Trial without catheter means the patient will be prescribed tamsulosin, and 1 to 2 days after tamsulosin, the catheter will be removed, and we'll see that if the patient is able to uh, void or not. So the patient is able to urinate without the catheter, then we'll say that trial without catheter is successful, and we will continue him on tamsulosin. While in second scenario, if after removing the catheter, patient is unable to urinate, then we will say that trial without catheter is not successful, and then we will think about doing a surgery. TURP or transurethral resection of prostate is the surgery that is done for BPH. And remember that an important complication of TURP is because excessive fluid is used for irrigation during TURP, which can be absorbed in the veins that are present in the bladder and the prostate area, and it can cause hyponatremia or delusional hyponatremia. So remember that whenever there's problem with the potassium, heart will be affected, and whenever there's problem with the sodium, brain will be affected. So during TURP, excessive irrigation can cause delusional hyponatremia. So if a patient develop confusion, agitation, seizures after TURP, then you will think of delusional hyponatremia. So remember this complication of TURP, that is delusional hyponatremia. How you will identify a delusional hyponatremia? If a patient develop confusion, agitation or CNS symptoms after TURP operation, then you will think of delusional hyponatremia.